roadmap for what I'm going to go through today. And John Kramer, how's your timing? Do you have to get off, John? Any chance, John Kramer?
I've got a half an hour for sure, hopefully an hour.
Okay, got it. All right, I'll try to see if I can front load you a little bit with Jim Augustine then. All right. So I'll make some little bit adjustments. So thank you for being here as usual. This will be fun today. And we have some good special guests, and I'm really appreciated that they're here. All right, so let's go to the slideshow. I guess I go to screen sharing here, okay, and then I will pick up this one. So here's everybody's horoscope for today. Not everybody, unfortunately, but many of you. So about you spending your time at home, no matter where you are. Let's see if I can get this slideshow to click. So again, welcome back, my friends, to the show that never ends. By the way, this was, as I told you before, has been put up at the Hard Rock Casino where we're going to hold the Eagles meetings this year. And so it'll be nice, hopefully, to greet us next year as we get there. One thing I just want to say, this is just kind of an interesting thing. Actually, Matthew McConaughey was on last night talking about, doing these video things. And part of one of the things I suggest is I see a lot of times people have light behind them. And this is what he was talking about. Make sure there's light in front of you, not a light behind you. Hopefully not a distracting thing like my little, transcendental mat in the back on the ground there. But the other main thing is sometimes they put it on a little box or a lift or something, or some books where it's up closer to your eye level. And so as a result, we get more of a straight shot than you looking down. So just some helpful tips and so on. Some of you probably are smarter about this than me, but those are just some of the suggestions that someone they said I should do. So, by the way, just for the purposes, again, this webinar is going to go out. Craig, do you want to talk a little bit about where we are on that? About how?
Sure. Yeah. Again, as always, we post this after the recording is completed up on EMS or useagles.org. In addition to that, after this week, we'll be posting them on EMS World. They'll have a banner and being able to share these with a few more EMS medical directors around the world. So we look forward to that. And as always, it's a great day and glad we can have these type of discussions. So thank you, Paul.
All right. Thank you. And thank you guys again, District 7, for putting this on. So just for the purposes of anybody who's just be clicking on, especially when it goes out, do you have any idea what the readership is out there? Is it, Craig, by any chance?
Yeah, I'm actually been waiting on a response from Hillary, the editor, to give you an exact number, but it's probably at least millions and millions. I don't know. No, it's
billions. All right. So let's move on. But anyways, for the purposes of those people who might not know who we are today, that this is, in a sense, a private conversation that goes on between us and our conclave. But we're glad to share what we've been talking about later on. So keep that in mind for people in terms of if there's any political or language or so on as we go through this. So the Eagles essentially for the people is a shorthand, if I can get this thing to click, for the jurisdictional EMS medical directors for the 50 or so of the largest cities of the U.S. And again, accordingly, if I can get this thing to play, okay. Many counterparts in Europe, Australia, New Zealand, Pacific Rim, etc. And this is accounting for about a third of the U.S. population. We don't look at this as that we're big shots. We look at it as that we have a lot of responsibility and we're concerned and we're helping each other out. And also there's tens of other millions globally in the other high-risk metropolitan areas of the people that are often on the call here with us today. So with that, I want to move in. Here's my cognitive roadmap today. We're going to probably switch around a little bit just to accommodate some of the players. But what I have in mind is that talking about is one of the first things we'll try to launch into after I get through, I think, Jim Augustine and John Kramer, is to talk about what I call PPE for the EMT and the first responder psyche, mental health, force protection, the multiple factorial concerns that we have there. Then also what I want to launch into after that is talking about a little adjunct to that is like, if people really do get this and did they get a myocarditis, did they have lung injury, do we need to look at among those who got sick to look at recovery and fitness, et cetera. That may be another thing to be at least planning in the back of your head as we go through this. And then I want to talk a little bit about, if anybody there on the phone with us today knows about serum harvesting and where we are on that. I know Peter is leading a discussion on that on another line right now. Maybe Peter Antivi, if he joins us, can go through that a little bit for us, or anybody else that is there doing this. And then we have a special guest today that's going to talk about that severe COVID illness is not high altitude sickness. And there's an article that just came out yesterday, so it's very timely. And then we will talk about the issue about people saying we should debunk the concept of heme negative, about the hemoglobinopathy. And then there's some counter arguments to say, nope, you got to keep looking at this. And then we'll look at this is what we're going to start off with, is sort of looking at the surveillance or the survey. And we'll try to see if the August one how he's been keeping up, because I don't know how he survives the ongoing surveys that he's running all the time. And then we'll have a little bit of a talk about closer look at all the various filters that we can get and what the problems are that are out there. And with that, you want to run the movie for me, Julian, and then I'll take over from there. Okay. This is things are more the same today than they ever have been. If we can get this to play, can't play, right? So, and if that's not going to work, don't even worry about it. We'll just move on. I'll save it for next week. Okay. So with that, all right. So can you guys hear me okay then at this point in time?
Yep.
Okay, good. Okay, so first let's go to, I'd like to start off with Jim Augustine giving us a report from the week, if you don't mind, Jim. If you got, we had a lot of surveys were going in and out. One of them, for example, was Denver saying they saw an uptick in their cardiac arrest. How are we doing on that one?
I'll have to ask Kevin, because everybody was responding to him directly. That was really an interesting observation. The call I was just on with the IFC, FDNY is running hundreds to thousands of cardiac arrests, and it's getting to their psyche a little bit. They appear to have an increased death rate from all causes, meaning these aren't just coronavirus, but these are people who didn't have their cardiac pacemaker placed because the hospital's not doing pacemakers, et cetera. So it'll be real interesting.
Yeah, that's what we were talking about, the collateral damage that may come out of this. That's very interesting then. Okay, yeah. Go ahead.
They're already finding that. Our other surveys this week, mask in the stations, many of you have implemented it. Our pre-arrival instructions, many of you have implemented that. And again, it's meet outside. And then awareness of cases, another few states have added that. And again, it's a civil liberties issue about you tagging addresses in your 911 system.
Right.
All right. Last night, we had the Michael Levy CPR change. We have 63 responses in so far. That'll be excellent. And as soon as Mike and I can work on the results of that, Paul, we'll get it to you and to the rest of the group. But it looks like a lot of people have implemented changes, or they're going to be done in the next couple of weeks in regard to CPR. What a great survey. I thank all of you who took time to fill that out. Really appreciate it.
So I think most of you on the line know what that's about. We did a survey to say, have you changed your practices because of COVID regarding cardiac arrest, whether you started, don't start at all, or terminated early, transport people to the hospital, and et cetera, all those kinds of questions. So that was very, very interesting. But going back, I'm getting some notes in, for example, Indianapolis has an uptick. It looks like Dallas has had an uptick in cardiac arrest cases. So we'll get back into that a little bit more maybe next week. This is always great because it gives us, I think, an insight to what we'll do. Anything else then from your end of
the testing issue is a big one. I went over it with the entire IFC audience, IFC and IFF audience yesterday. A lot of departments, they're anxious to get into this antibody testing just so they can say that they are doing something. Again, based on what Mike Osterholm said and others, this is the Wild West, and it was officially tagged the Wild West. As of yesterday, 106 companies have registered with the FDA to do coronavirus testing. And there's no science behind, and all these emergency use authorizations, very dangerous time. Don't let people push you to do something just so you can say you're doing something.
Yeah, there's some of these private companies opening up. Just in my own city, I was listening to the radio this morning, news radio, just to catch it up on stuff. And there they were throwing it out that you could come down and get your antibody test done for whatever amount of money, right? So which is interesting. Okay.
This morning, saliva testing was the first saliva test, so you spit in a bottle rather than have your nose biopsied. So that it would be nice if we could spit in a bottle instead, looking for the virus. So the first one of those went out. I don't know how quickly that will be available commercially. The supply chain still broken, and that was a very important report I just received on the last call, that the supply chain, even if you think you've ordered 20,000 masks, if they come into the country, a lot of times they're being held and then reallocated. So very dangerous time in the supply chain. Paul, thank you for the opportunity to present. Let's go to the beach, which is behind you right now.
Yeah, exactly. So I'm on a Greg Taverna there. Hey, yeah, yes, Peter.
I just wanted to comment, Dr. Adams, and I'm reading off my screen here, commented yesterday, made me aware yesterday that the FDA has now said that if the company does not have an EUA, then essentially they're automatically by default now considered a high complexity CLIA lab, which means that either you have an EUA, which only one of the blood tests do, that's Celex, or you link up with a high complexity CLIA lab. Good luck with that. So as it stands right now, which all goes through CMS, right? CLIA, the CLIA certification goes through CMS, and so there's some other roads to navigate now rather than just buying these tests. So just word to the wise. That's on. And I called the FDA yesterday. I spent an hour on the phone with them, and they did confirm this finding. Just FYI.
Okay, thanks. And thanks for the good work, Peter, you did for us last week. We may do another catch up on it maybe on Friday or next Tuesday.
Hey, Paul, it's Craig. Can we go back to Jim? And Jim, what did you mean exactly by reallocation when the masks are coming through?
Yeah, that literally, so this is the supply chain expert who said, if these are coming in, the Customs and Border Patrol are working with the federal authorities and reallocating what comes in. And reallocation means they decide what the priority is. Current priorities, according to them, are 50% are going to the high impact areas and 50% are being distributed everywhere else. So you may think you have something coming in, but in fact, it gets caught at Customs and Border Patrol, and then they assume the inventory, no idea where the payments get shifted in regard to that. But that has been a real significant issue of people being able to get what they think that they're going to get in the supply world.
All right. Hey, Erica Carney from Kansas City was asking a question, Jim. He goes, how did you get the International Association of Firefighters, IAFF, IAFC, receive that information? Antibody testing was, like she said, just like I'm hearing, is a big push today, et cetera.
Yeah, and so that was, I'm on the coronavirus task force for the International Association of Fire Chiefs, and that we have conference calls twice a week. IAFF is heavily represented in that, and their leadership is the one that is significantly pushing that we need to do something. Many of you have heard this from your locals.
Yeah. All right, and then so just as I pivot on to the next person, just wanted to point out that for those who don't know, Jim Augustine has been our librarian of our surveys, et cetera, and a great representative for us to the International Association of Firefighters, Fire Chiefs, et cetera. And also in himself as a medical director, and over the years has been great service to us all. And and previously also on the board of directors at ACEP as well, the American College of Emergency Physicians. All right, so let's move on then to the next topic, I think, that we can do. John Kramer, maybe as the director of EMS at NITS, the National Hypertension. Can you get on, John, and see if there's anything you need to report or anything you want to talk about?
Oh man, it was nice having a virtual day. Thanks for asking.
Okay, so someone's got back there.
It was nice to be asked anyway.
Yes.
Thanks, Paul. A couple of update things. The first thing that I want to mention, as part of the FEMA Healthcare Systems Resiliency Task Force, there had been a number of critical care webinars set up. There's actually a series that started out with ICU critical care activities. Then they added on emergency medicine, emergency department webinar series. and last week was the first of an EMS series. Unfortunately, that first one that was scheduled was on Friday at noon, which conflicted with part of the Eagles conference that had been, or Eagles webinar series that this is a part of, that had been previously scheduled. I think it's important that folks understand that there was nothing intentional in that scheduling. It was not done with a desire to conflict with Eagles. In fact, the input that I'm taking back and others that are taking back to the task force from all of these Eagles webinar series is very helpful in providing a real world experience to everybody. So for folks that were concerned that this was scheduled to conflict with your call last week, it was purely a scheduling issue. It was a time when time was available.
No problem. That's fine. Okay. So anyway,
yeah, it was just important to make sure that was clear, and it will not be scheduled in the future to conflict with.
oh, fantastic. Okay, good. Okay, go ahead. Then anything else new from your realm in the feds?
Well, I just want to again reinforce the fact that really listening to this dialogue is important to help us with real world truth and to understand what's going on, outside the federal beltway, if you would. Jim's comment about some of the PPE issues with Customs and Border Protection, I feel a need to also caveat that one of the big missions that CBP has is to intercept counterfeit products as they're coming into the country. And quite candidly, that is a lot of what they're doing at the border when counterfeit PPE, when suppliers try to get counterfeit PPE into the country. So the material that's coming into the country certainly is distributed and allocated based on need. It's not just allocated and distributed based on what everybody wants at that particular time. But PPE is coming into the country and the suppliers are getting inventory that they are able to distribute to their folks. I also want to reinforce the comments that Jim made about the testing quagmire that's going on right now, because it really is a free-for-all, and the FDA and the CDC are trying to get a better handle on it, but it is, there are a lot of folks out there that can't validate what they're trying to do with their testing. The two other final things, and I know you're going to talk about mental health issues and behavioral health issues later in the program, but there are a lot of activities going on as part of the task force to make sure that behavioral health issues for all of the healthcare sector, including EMS, are being addressed. And finally, we've gotten a number of questions asking about information from the various modeling programs about how the disease will continue to spread over the country and things like that. There are a number of modeling programs that are used to make those projections. All of that information is shared with your folks at the state emergency management level. So if you're looking for particular modeling information for state, city, or county, your state EOC should have access to that information.
Okay,
Thanks.
that's fantastic. Oh, thanks, John. We're so privileged to have you on board with us all the time. It really means a lot. All right, so then let's let me then go into this issue about the mental health issues you just brought up as well. And so I'd like to turn this over to Chris Colwell, if you're there. Are you Chris Colwell, EMS Medical Director of San Francisco? Are you there?
Yep.
Hey, Chris, if you don't mind, if you can talk about this issue about, as I call it, the PPE for the EMT and first responder psyche, right? If you don't mind, if you can address that a little bit, and just mostly just to put this on the table, and so people are starting to think about it now, because there is psychological impact for the society at large, and I can't imagine that it must be worse for our first responders, as we've just heard with the cardiac arrest stuff and so on, that's having an impact. So can you take it away? And good to see you. Good morning to you. Okay.
Thanks. Good morning, and good morning, everybody. And no, we had talked a fair amount about this in the midst of all of the important topics that we've already addressed today. And you know, the intubations and the PPEs and the proning and all these kind of critical medical issues that we're dealing with. And we haven't even, you know, touched the surface of the testing. Amongst all of this, I think everybody has been aware and thinking about the mental health issues related to all of our providers and the real challenges that now as we get into 6, 7, 8 weeks of this, you know, what that looks like for sustainability, what that looks like for long-term issues. And I don't know if anybody has the answer. I certainly don't. We've tried a number of things here in San Francisco with varying success. We tried to do a social distancing bike ride that had some success. We certainly had we had a number of people come forward from UCSF Psychiatry to offer free services in a whole variety of different therapy areas that some of our providers have really found valuable. And so we're kind of one of recent issues was it was a virtual social hour, or happy hour, where we were able to use kind of some of the technology that is so nice nowadays, and really have what amounts to a happy hour with a group of, and we got 85 people together, mostly pre-hospital folks that really had a good time. I found it actually extraordinarily valuable, and found myself finishing that feeling as good as I have in probably 8 weeks. So. Just lots of different things going on. I know a lot of different agencies are trying some really cool things, and in reaching out and learning more about what other people are doing, I found out some of you may know Lauren Maloney. She's a paramedic and physician, and now the EMS fellow at Stony Brook, and has really explored on a number of different levels this as well. And so, in learning more about kind of some of the cool stuff she's doing. I just wanted to bring this topic up and talk about, hear what other people are doing as well, what they found valuable, and would love to maybe, if I could, call out Lauren and have her talk a little bit about some of the stuff she's doing, because from what I can gather, it's really cool
this
stuff.
is Mark Contarato. I just want to bring up one thing that was mentioned earlier, is that Oregon Health Sciences University has sent out a fairly general COVID-19 surveillance survey that they're wanting healthcare providers to take, and it's at all levels from physicians down to first responders. That basically are looking at what kind of PPE are you using? Are you reusing it? Are you cleaning it? Getting demographics, and have you gotten sick since this? Have you tested COVID positive? I did it yesterday. I think Mike did it as well. It takes about 5 minutes, and it's about 30 questions. And I talked with Mike about it, and I was going to try to push it out to all our EMS staff to take it on a voluntary basis. I'll probably try to push it out to the hospital as well.
Okay, thanks. Chris, do you want to go ahead and get back then and on the issue of the mental health issues for
Any questions on the survey?
Mark, I'm not sure. We'll be glad to do that. Why don't you get in touch with Jim?
Okay.
Ogden, we can put that out. Okay, how's that? All righty. Thank you. Anyway, back to you, Chris. Okay.
So anyway, I was gonna ask Lauren if she could maybe talk a little bit about some of the stuff she's doing, and again, for any of you that don't know Lauren, yeah, she's a paramedic and physician and EMS fellow at Stony Brook, and really doing some cool stuff here. So Lauren, would you help us learn a little bit about just some of the stuff you've done?
Yeah, hey everybody. So we are trying to also do the Zoom happy hour, where if you have a seltzer at work or whatever, even if it's just 5-10 minutes, to try and encourage folks to just kind of laugh and hang out together remotely. Other things that we're doing, we're fortunate enough to have 9/11 clinics out here. So we've been trying to tap into resources that actually get what we do in EMS. So that way, if we do have a provider that needs help, that we have folks that kind of get what we do, that otherwise might deter people from saying, hey, I need to talk to somebody. And so we've actually had a couple instances where we've been able to hook our people up with telemedicine psychiatric consults in case they need it, just as as kind of a safety net. We also have been collecting teddy bears. So for when first responders get admitted, it's just statistically, it's probably going to happen. So we have teddy bears. That way they know that their people are thinking of them if they're especially admitted to an ISO kind of quarantine. We've also been doing some therapeutic chalk graffiti, some art therapy with our medics of, the duty crews just trying to keep morale up. And then we also have tried to start to do something called a code lavender, which is more common in hospitals, of basically saying, we focus a lot on our patients, but we also got to take a pause and focus on our providers. So how can we have kind of a multidisciplinary awareness of saying, hey, listen, it's okay to just sit down, take a breather, have some water, feel your feet again, and just reconnect as peers. So that's what we're trying to do. So far, it's so good. The teddy bears was a huge community effort. I had people randomly dropping teddy bears off on my doorstep, which is exciting, somewhat creepy, but fabulous overall.
All right, and I'd be curious to know if anybody else is. Thank you so much. And Lauren, you guys got awarded a grant, right? What was that about?
We did. We just got a seed grant from SUNY overall to start working on ways to allow for safer intubations by chapping aerosolization, especially for EMS, since you can make an argument those are probably some of the highest risk airways that are being managed with variable availability of PPE and time constraints. So we're super excited to be able to start working on that for our folks.
Good. So if anybody, get in touch with her, if anybody has any ideas and can help her out, that level, that's great. All right. So let's now move over to, first of all, I saw Ed Rock there. You've got 36, or it's probably going up every minute, 37,000 paramedics that are working for you at the Global Medical Rescue. Ed, if you're on, can you tell us a little bit? Are you doing anything or have any proactive programs there? Or are you thinking about doing it? Regarding
good morning. Yeah, good morning, everyone. I think, Paul, we're going to join you on the seafront environment next time.
Oh yeah.
So we, and I'll tell you, like everyone on the call, it's probably my most expanding worry. In communities, depending on what the illness burden is and what the particular makeup of that community is. So as part of our FEMA deployment, there's significant concern about mental health. Yesterday, 2 of our EMTs ran 6 cardiac arrests back to back, requested actually to either have downtime or be demobilized. It's something they've not seen before. We've implemented, we found that the peer-based approach, so we've implemented both on-the-ground peers whose function is to essentially check on everyone. They have essentially CISM OID training, or our CISM, so that's their background. They can escalate. We've got a 24-hour nurse navigation line to provide support. And then 4 days ago, we started, we've got a relationship with mental health providers that we do telemental health consultations. So we've got tablets on the ground if the peers want to escalate the discussion to a mental health provider, and their crisis social workers, psychologists, etc. They link in directly and have that discussion. It's been utilized fairly aggressively, which is good and bad, obviously. But it is, there is a sense in some particularly high illness areas, as everyone knows, of a little bit of despair. When will this end? Interestingly, and importantly, probably, there is a sense of guilt with crisis standards of care, something I'd never thought about, but this concept that I'm making a decision to not initiate resuscitation or to terminate resuscitation earlier than I would because of something that's contagious. So am I doing that selfishly to protect myself at someone else's expense? The guilt of, who goes to the hospital, who doesn't. A fair number of these folks plead to go to the hospital in those communities where the non-transport approach is in place. Our folks have to communicate that. So I worry about this a lot. I worry about the long-term impact on Our folks, I think the non-heavy illness burden areas are waiting for it. So as soon as, and I haven't even seen it, but as soon as something hits the lay media, so the resurgence of cases in China or the secondary cases in South Korea that had been deemed to be illness-free, when that stuff hits, it really cranks folks up appropriately. So we're doing everything we can to disseminate that via telehealth, via online peers, and via on-the-ground peers. But it's evolving, and it's our next demon, I think, with our folks, because this is something that none of us had ever imagined would happen.
Yeah. All right. So yeah, this sounds like this is really timely that we start talking about this uptick in cardiac arrest and the issues you're talking about. I mean, you've heard me give talks on this before, on the issue that guilt is the big thing that comes out in any major tragedy, whether it's an individual or if it has to do with a major crisis, et cetera. And so you're right on target there. So keep that up. And I guess that's Hillary, I think, is on the line with us right now, Hillary Gates. And we've talked about this, is that we're glad that people feel that, because that means they're still human in all this. And yet at the same time, we got to let them know that's a natural feeling and get them around it. So we got to have a safety net there. All right. So anybody else have any other issues we can, or suggestions on that end that we could bring up before I go to the next topic? Hearing none, let's keep track of this and let's move on. But we want to make sure we put that on everybody's radar screen in the meantime. So, all right. So the next thing I wanted to go through is I was going to talk about the issue about recovery and long-term health, et cetera, especially those who've got sick. Let's table that till later on, but keep that in the back of your head about making sure that we're doing pulmonary function tests or stress tests or whatever. If we did have someone who got really sick, I think that'd be important to make sure for their health. And we still don't know if this thing is going to have long-term consequences for some people, or relapses even in some situations. And that sort of seems to be percolating up possibly in Asia right now as we speak. All right, so let's do this. And I want to talk a little bit about the issue of the non-hypoxic hypoxemia. In other words, hypoxemia does not equal hypoxia, at least in the early stages of the disease process. And so one of the things that came out recently is that people have been floating around the concept this is like high altitude illness. The only association I think I've ever made has been to say you wouldn't be intubating someone on the top of a mountain with a 65% saturation. That was the only analogy I think we've ever made to that. But there have been people floating around that this disease is like acting like high altitude sickness. And so there was a nice article that came out. I don't know if I can show that here or not, but let's see if I can get this to come up. Can you guys do the screen sharing for me here by any chance? Can they see this right now, Jillian? I'm not sure if they can see my slide. Is that right? Does that come up?
No, we can't see it, Paul. You gotta go to share screen at the bottom of the Zoom, that green button.
All right. Well, actually, it doesn't really matter then. Let's just get on with this. But the person who wrote this, a senior author on this, is Peter Hackett. If you don't know who Peter Hackett is, first of all, he is without a doubt the guru of high altitude illness. Okay. Done more experience, been doing more trekking and more studies than anybody else in this area. He lives up in Telluride right now, where he used to run the emergency department, and is doing some major consulting. And there's a journal, High Altitude Medicine, and he just recently, yesterday, published an article that came out ahead of print on COVID lung disease, not high altitude pulmonary edema. And so it's just a privilege to have him on the line. I get to work with him in a lot of cool venues, and but also I have to say that part of my errant behavior is probably due to his role modeling, as he was my intern when I was a medical student back in San Francisco. And so with that, so Peter, if you don't mind, take over and just give us a little your blurb on this, and maybe a Reader's Digest version of your paper that you put out yesterday.
Okay, Paul. Yeah, I'm not sure how I can be most helpful. Can you hear me okay?
Yep, you're doing fine.
Okay, so this notion came up based on observations that the COVID-19 pneumonia seemed to be atypical. And there's a lot of debate around whether it's really atypical or whether it's just so heterogeneous within but still fits in the category of ARDS. So there's a couple interesting observations. One is that these people come in extremely hypoxemic, and some don't seem to be that symptomatic. And that fits with high altitude pulmonary edema. We see people here in Colorado come in, oxygen saturations of 50, 60%. They're awake and they're talking. And I think most of that has to do with it takes a couple of days to develop. It's not like an acute drop in oxygen saturation, which would render you unconscious if it's within minutes. But if it's over a period of 2 or 3 days, a lot of people can tolerate it pretty well. The other thing is that we know that there's a heterogeneity in the hypoxic ventilatory response and the body's response to hypoxemia. And about 15% of the population don't have much of a carotid body response. So when they get very hypoxemic, they're quiet, they turn blue, their mind goes off, they go unconscious. They don't put up a fight. They don't have respiratory response like most of us do. And so I think some of these observations have to do with seeing patients who have a blunted hypoxic ventilatory response, and that's just the way their individual physiology is kind of genetically determined. But in terms of trying to compare the high altitude illness with the COVID pneumonia, I mean, yeah, there's hypoxemia in both. In high altitude illness, the whole cascade is triggered by alveolar hypoxia, causing uneven hypoxic vasoconstriction and pulmonary hypertension. In the COVID pneumonia, hypoxemia is secondary to inflammatory process and permeability leak. So in HAPE, in high altitude pulmonary edema, the leak is capillary hypertension. It's a hemodynamic pressure induced mechanical kind of leak. There's no primary permeability defect. There's no inflammation until later on in the course. We've done bronchoalveolar lavage on a lot of these people, and we can follow the inflammation is cleanup after the leak has taken place. Whereas in COVID, it's primary inflammatory process and a permeability leak. These people don't have pulmonary hypertension. Actually, I haven't seen any measurements of pulmonary pressure. Maybe some of you have, but there haven't been reported. But it's unlikely they've got significant pulmonary hypertension, just like most people with ARDS don't have significant pulmonary hypertension. And if you were to give them pulmonary vasodilators, like you do with altitude illness, you could increase VQ abnormalities and increase shunting and make them worse. So that's the concern. So although there are similarities, especially in terms of the severe hypoxemia, the pathophysiology is entirely different, and the approach, other than oxygenating them, needs to be different as well. That's my 5-minute take.
Yeah, that's great. And there's no greater expert on this, so I just wanted to put that out there for the record and put that one to sleep, so to speak, and which is really appreciated. Just great to see it too, and thank you so much again for being here. And please stay on to hear. So one of the other things we're talking about is the possibility that this has maybe it's a hemoglobinopathy. And so that's, there's a recent article that came out that said debunking it. We're going to send all that information out to everybody. And it says debunking the hemoglobinopathy theory. On the other hand, there are probably counter arguments to retrunk it, so to speak, as I call this next section we're going to get into. Are you heme positive or heme negative? In other words, debunking and retrunking the hemoglobin pathophys concept. So for that, I wanted to maybe put one of our brainiacs on I think both Ken Shepke and John Jew are there. Ken, the Florida State Medical Director, is a biochemistry nerd. So Ken, have you looked into this at all? And can you talk to us about that? We'll see what your reaction is. And Peter, by the way, thanks a lot. That was terrific.
Sure. I'd be happy to. And yeah, I think obviously while I think there are some similarities with HAPE in terms of the rightward shift of the oxyhemoglobin curve, we're obviously not dropping people off the top of Mount Everest. So I think there may be some similarities with high altitude pulmonary edema in terms of what we're seeing for the dissociation of oxygen in the capillaries and the small tissues. But the phenomenon we have to consider, regardless of what the mechanism is, I'll be the first to say there's a lot of things going on here that we don't quite understand yet. We're just developing theories. Something is causing the oxygen affinity in the heme molecule to be lower so that a person who has hypoxemia does not demonstrate hypoxia, meaning we are seeing true matching O2 sats with arterial blood gases. So the early theory was that, hey, maybe our O2 sats are wrong, and this guy who's 70% talking to me and seems fine. It's maybe there's something making the pulse oximeter misread, but that's not the case. The arterial gases, blood gases are actually matching that. So it truly is a hypoxemic state. Yet there's no lactic acidosis, meaning that there is no anaerobic metabolism going on. So I don't think it's an issue with hypoxemic drive. I think there's truly not hypoxia. So, and this raises some interesting concepts for future treatment modalities, because there's something going on with this particular disease that it's allowing the oxygen to disassociate from the hemoglobin molecule in the smaller blood vessels to the point that the tissues are not becoming hypoxic, which has theoretical treatment regimen for future stuff when we pass this disease for any ischemic state where there's a penumbra of ischemic tissue where you can offload extra oxygen into the tissues. So I think that's one thing that's exciting. When you look at some of the mapping of the open reading frames with hemoglobin and beta-1 chain, it does look like there is some association that could occur between COVID and hemoglobin. That can be an interaction. I know there was the article that debunked this, saying that COVID doesn't actually enter the red blood cells. I don't know if that's true or not. I did see that. I'm still kind of scratching my head over why is there reports that people with type A blood have issues, which kind of suggests that there is some interaction with erythrocytes. I don't really know. I know, Paul, you raised the issue with hemoglobin A1C. I'm not sure that it's hemoglobin A1C is the issue with diabetics, that's a particular risk factor. It may instead be the upregulation of the ACE2 receptor that we see in people taking certain antihypertensive medications and diabetics. The ACE2 receptor is the doorway, if you will, for this particular virus. So maybe that upregulation of ACE2 is the common pathway for some of these comorbidities having a worsened outcome. But I think back to the issue at hand with the hemoglobin, whether it's direct binding or interaction with the hemoglobin and this particular virus, or whether it's has to do with heme metabolism and an induced porphyria. These are all theories that are out there, but regardless of what the ultimate end game is, there's one thing that seems, at least so far clinically, that seems to be irrefutable, is that there's a rightward shift in the oxyhemoglobin curve, and we need to figure out why is this occurring.
Yeah. And then John Ju, one thing that did give some stock to this is the article that came out of China not too long ago. What's your opinion of that, of the quality of that work and so on? Are you there, John?
Yeah, I am. Kit,
welcome.
Can you hear me?
Again, Ken is from the West. Yeah, I can hear you. Ken, of course, is from also not only the Florida State Medical Director, but from the city of West Palm Beach. And John is got the city of Portland and surrounding county for the last, 5 decades, or whatever, right, John? So
yeah. Thanks, Paul. I'm sort of scratching my head too. I've been around for a long period of time, and I've never seen this from an infectious disease point of view. The problem that occurs is that there are, at least for my critical care colleagues, at least 2 presentations to critical care. One of them is severe hypoxemia without obvious significant evidence of ARDS. And this is a patient with normal compliance lungs and at times pulmonary hypertension, yet unexplained, versus the other classical ARDS. The article I forwarded Paul was a biochemical Chinese article that actually looked at the metabolism of heme and basically suggested that the COVID-19 SARS-CoV-2 virus actually causes a metabolism change in the synthesis of hemoglobin and basically blocks the ability for the affinity for oxygen on the hemoglobin per se. But Ken's I would say observations are clinically correct, but I think there is within the critical care circles a clear shift to the right and a clear, I would say, if you look at the European critical care, there's an L form and a H form. H is classical ARDS, L form is atypical presentation where there is significant hypoxemia without significant pulmonary findings here as well. There is a good thread, and this is backed by infectious disease circles, of microcapillary thrombosis with the activation of the inflammation of the endothelial cells, and basically you have microemboli causing pulmonary hypertension. There is good pathological evidence from both SARS as well as the recent autopsy from Louisiana that actually looked at a couple of cases that matches both MERS and 2003 SARS as well. So I think there is some evidence, pretty good evidence, that there is microthrombosis at the capillary level in some of these causing pulmonary hypertension and VQ mismatch.
Yeah, and then so this is, again, we just don't know. There's nothing pathognomonic about this. There's different stages, and you're catching at different points. By the way, the H form and the L form he's talking about, what it refers to is they're the ones with the kind of more classic ARDS-like pattern, where there is a low lung compliance, that kind of thing. Whereas the H form is where you have a high lung compliance, and you can actually, or I may have them backwards, but the point is that one has a stiff lung, one doesn't, and that's what it gets to. The other thing is that the microinfarcts are kind of interesting. There are probably all these other things happening. The myocarditis, is there encephalitis there? Is there are they having lacunar infarcts? We don't know. We need to be tracking all this stuff. And certainly it seems like it starts as a pleuritis in many ways, especially the people who are feeling a little stiff lungs when they're trying to breathe. It's probably more a pleural thing, and then it expands maybe into the other areas of the lung. We don't know, but it may be different for different people and so on. But John is, by the way, also a boarded infectious disease expert. That's why he's such a brainiac. I have an inverse ratio IQ with him. So it's really terrific to have you on the phone there, John. Thank you so much.
One more comment, Paul, and I don't know the answer to this, is that some of our critical care people are anticoagulating people. With demonstrated pulmonary hypertension, especially by bedside echo.
Are they using heparin or TPA? Or
they're using heparin. Some of them, if they're in deep trouble, are using TPA, but that's completely anecdotal. I have no idea what the results are.
Yeah. Hey,
Paul,
Ken.
can I make a quick comment on that?
Yeah, sure. Please do, Randy.
Yeah,
Randy from Hollywood, Florida, by the way. Go ahead.
We just, that was something that we heard, and we started doing thromboelastography on these patients in the ER. So we've done a small sample, and we found various results depending on the stage of illness. So we just submitted an IRB to our Memorial IRB board, and we're going to start collecting tags on all the confirmed positives in the ER and compiling those results and take a look and see what we find. We may find that, and what we found is some of these patients that had advanced disease were actually hypocoagulable on TEG and would have bled out with heparin, and vice versa. So I think it may be not so straightforward with respect to that.
And we're doing the same thing at the General now with TEG, just starting next week, where we're going to test all of them on the TEG as well.
Which I think is a good plan, because again, this thing is so chameleon and chimeric and all that, as we've talked about before, but also you may see them at different stages in the disease process. It may very well be that there are people that later go on to the cytokine storm and go on and have worse disease, and we may be catching them at different times, and they may also, in individuals, present in different ways, as we've just heard, at different times. So,
Paul, just another comment, if I may. Also, keep in mind that the autopsy reports that have been done in almost any form of ARDS when they go to pathology have microemboli.
Yeah.
And that doesn't seem to be particularly unique to this type of ARDS.
Yep. And I think they're reaching out, although this may be a little bit different ARDS in the sense that it may be more of starts off as a pneumonitis or whatever, it spreads, and just a little bit different than the seeding that you probably get from a multi-organ failure, cytokine storm. It's a different animal. That's what this is coming down to. One last thing on this issue, so we can move on. We got some other topics. Ken Shepke, you want to just tell us, like, maybe in a 30-second blip about the methylene blue study that you were telling me about that came out of
this is another interesting phenomenon. It's I think I may have shared it with you, but this comes out, I think it might have been, it's Europe. They had 25 patients that are on methylene blue as apparently part of their cancer therapy. As you know, chloroquine and hydroxychloroquine are actually derivatives of methylene blue. Methylene blue is the parent compound, and has a whole host of biochemical reactions, including its effects on heme metabolism, among other things. And these 2,500 patients in their registry, while I will caution everyone that there is no control here, they've been following these folks, and none of them have developed any severe COVID symptoms. So whether that's just because they're really, really good at social distancing, or there's some effect, some prophylactic effect of methylene blue, which then would extend to the theories on chloroquine and hydroxychloroquine as well. Maybe there's something there. I don't know. I'm just putting it out for food for thought.
So we're going to take all these articles we talk about, everything from the high altitude, this is not high altitude sickness article to that Peter put out yesterday, to the methylene blue, to the debunking the theory about heme, and then the other ones that John was talking about in terms of affecting the porphyrins, et cetera, metabolism, et cetera. We'll put those on the websites for people to read if you want to see those later on. Okay. Any other issues? Anybody else want to bring something up from their regions on this topic before I go to the next one? And if not, Craig, you want to take over and talk a little bit about the getting off, as I call it, don't get off kilter with the filters you get, right?
Be happy to. We invited a guest, Holly Stewart, who I think most of you know is a respiratory therapist and has been very supportive of EMS. Her disclaimer and conflict of interest is she does work for Medtronic, but she had brought to attention a few issues regarding some of the filter issues with ventilators and bag valve masks, and I thought it might be worth a minute or two for her to spend with us, just to give us an update on filters and where they are. It's something that I think we've always probably taken for granted in critical care transport, but obviously has a increased awareness with COVID. So Holly, we'll turn it over to you if you want to spend a minute or two with us. So,
can you hear me okay?
Loud and clear. Go ahead.
Awesome. So I just wanted to go over a couple review of the filters that are available. So mechanical filters, again, these are the ones that are being recommended for ventilators. The reason being is they avoid the passage of liquid and the colonization and blockage. So what it looks like is the filter looks like folded paper inside, and they can be used on the expiratory limb, inspiratory limb, and at the patient Y. They can also have a heat moisture exchanger for non-humidification ventilation. And you can use these at, again, the patient Y or bag valve. Electrostatic filters, again, a lot of these show the same type of filtration efficiencies. However, the electrostatic filters are kind of white and fibrous, and they are not recommended for high moisture environments. And there is a concern here that if the electrostatic filter gets water or humidification or secretions in it, the actual filter barrier is broken, and the virus contaminants can get into that ventilator circuit or bag valve. So I showed on the right-hand side, so recommendations for where to place mechanical filters on ventilators is on the expiratory side. If you're using, in many EMS services, you might be using a J circuit. They'll put it on the inspiratory side, and you may also want to include a filter at the patient Y for additional humidification and filtration purposes. On the bottom graphic, I show, again, a mechanical filter with HME. You can have a little bit of dead space there, and also we put the end-tidal CO2 behind the mechanical filter. And just a cautionary note here, if you put end-tidal behind your filter, you may have an increased resistance, and therefore with side stream types of capnography, your waveform may not be like it is when it's connected directly to the ET tube. Filters in the mechanical and electrostatic, recommendations are for changing these every 24 hours. If you're using mechanical filters or electrostatic filters with humidification, you may have to change these more often, or with nebulization. So just realize that your filtration properties and resistance in the filter may be reduced because of the moisture in the humidified patient circuit. So Craig, any questions?
Yeah, one question would be, we've had some issues with trying to find filters. Any thoughts or ideas from the manufacturing standpoint of ways to obtain the filters for us at this point in time?
Unfortunately, like all other forms of PPE equipment, with all manufacturing increasing production, a lot of these filters are actually not made in the US. So we not only have to ramp production, but transportation of finished goods and importation is also a challenge for all manufacturers. And so everybody is experiencing shortages. So the rule of thumb, if you can filter, that's the best. If you only can get access to electrostatic, you use that. Preferred is mechanical. So that's unfortunately the advice we have to give.
Got it. And then on some of the transport ventilators, people are suggesting we put a filter on, either the gas inflow or outflow, I guess, trying to protect the environment. Have you seen anything like that or know of any recommendations in that particular area?
Yes, so if it's a J circuit, so you don't have like an expiratory limb going in, you place your mechanical filter on the inspiratory side. That is the recommendation. If you do have a dual limb circuit, then you place the mechanical filter on the expiratory side. And then you can also place a filter right at that patient Y, as the picture shows.
Got it. Yeah, this I was actually referring to the ventilator itself and things, and so that's where some of, not on the circuit, and I didn't know if that was overkill or needed, or I don't know if the theory is to protect the machine for next patient use or what that might be.
It's actually both. So it's to protect the providers, but also it's to protect the device itself. So no contaminants can get inside your ventilator. And again, it's a big deal. And making sure some acute care ventilators do have heated mechanical filters inside of it, but most do not. So that's why there's a high utilization of mechanical filters in the critical care areas as well as EMS.
Well, awesome. Thank you so much. We appreciate you spending some time, and your expertise as a respiratory therapist is always greatly appreciated. I don't know if there's other questions that others may have at this point in time.
Anybody want to pipe in on that one, or else I'm going to move on and do the reports from all the different areas.
Well, it's Joe Holly. Can I ask a quick question?
Yep, Joe, go ahead, please. Joe Holly, you're in Memphis, Tennessee, I hear. Was that right?
That is correct. That's correct.
You have a bass guitar back there. That's even cooler. So.
Oh, I have several. My question is really related to the use of things like N95 mask material, et cetera, as a viral filter, a makeshift viral filter, and whether or not that has any, whether or not the inclusion of any of these filters may impact the end-tidal CO2 reading itself.
So when, again, that hasn't been tested because it all depends on the actual filters that you're putting in line. So as they fill with fluid, you have an increased resistance. And therefore, when you have a draw or a pull from the end-tidal CO2, you may see a dampening of the end-tidal CO2 waveforms. So that is also another indication that you may need to change your filter as well. So if you start to see a dampening, that you initially had a nice square waveform shape, and then you got fluid or secretion in there, and then you start to see a lengthening of that end-tidal CO2 capnograph, that's another indication that you may have an occlusion. So just be aware that it isn't as crisp and clean as if you have it right on the ET tube.
All right, any other questions from the peanut gallery, so to speak? And then if not, let's move around. Let's see what's happening. I'll take my reports in from around the country and around the world. If I saw there's a 337 number up here. I don't know if that's Pierre calling in from France or one of our other folks there. But who's 337-298-1111? Can you tell me?
Hey, Paul, Chuck Burnell. I had to get off a video. I'm on sale.
Okay, good. Just wanted to make sure I knew who it was. I may check in with you later. Then I have a 719 number here. Who's that? 719 362, whatever it is. I can't read it very well. Whoever 719 is, can you tell me who you are? Okay.
Yeah,
who is it?
That's Stein Bronsky. Paul, that's Stein Bronsky.
Oh, good, because I'd love to call on you, Stein. I just wanted to know who it was. It's not identified here. Okay, so that's good. All right, good. I want to see if there's anybody else I don't know. Who's DM? DM?
She's with me, Paul. That's my daughter. She's
okay, got it. Okay, got it. Okay.
She's one of the greatest ER nurses in Texas. So.
Oh, fantastic then. Okay, good. Just wanted to make sure I knew who I was calling on or not, or missing or whatever. I'm going to start maybe really quickly from. Well, I think what I'll do is I'll go to Rob Lowe because we haven't heard from him in a while, or I haven't called on him in Columbus, Ohio. How are things in your 911 system, Rob? What's going on there? Hey, Rob, can you hear me? I gotta get him unmuted, I guess, or whatever if we can. If not, pipe in when you can. We'll. It's the usual thing with these sessions. So from that end, let's go to the far northwest part of the world, Oconus, outside the continent. Well, you're actually part of the continental United States. And Mike Levy, what's happening up in Anchorage? Anything new to report on from your end? If you can hear me, Mike, can you?
Yeah, I can hear you.
Yeah, good. Go ahead.
Actually, pretty status quo, thanks. We're prepared. We have a few hundred cases, but I think compared to a lot of places, we're doing pretty well.
Then, do you have a large homeless population there and issues with that?
We have a large homeless population, and we have a large public inebriate population. And so we've worked on taking our two largest facilities, two large ice rinks, and they've been repurposed for housing homeless people with a 6-foot perimeter to give that 36 square feet of space. We've taken the large auditorium on the university campus and made that into an auxiliary hospital. And now I'm working through a process with very limited supplies to do rapid nasal swab RNA PCR testing on homeless inebriates so that we can get a quicker, mostly yes/no answer on these folks before we throw them back into the stream.
Okay, and you're the incoming president of the National Association of EMS Physicians. Anything new to report from your last report you gave on Friday?
Not really so much, just watch your mail. We have some town hall coming up most recently. I forget the date. I think it's this Thursday, but correct me. I don't have it in front of me. Will be
Usually
legal with Matt Strager.
Yeah, good. Yeah, usually it comes up on Thursday afternoon, so we'll look for that. Okay, so let's move on down the coastline. John, anything new to report from the Portland area as I go through there? I don't see Seattle on the line, so I'll go to you.
No, we've actually done fairly well with our social distancing. Remarkably, our cardiac arrest numbers have just gone down by a third as well. So I'm not quite sure what's happening. Our STEMIs have gone down as well. So I think social distancing may have an effect in our community. On the other hand, we have a number of, I would say, out-of-hospital deaths that our medical examiners are seeing and testing, and some of them are COVID positive. So it's sort of a mixed picture in our community.
So I'm going to suggest that we as a group start looking at this issue. Kevin McVaney brought it up from Denver. We're seeing the same thing in Cincinnati. So I think that we may want to have a paper to show that the cardiac arrest rate went up. And if we can get autopsy data, at least from some of the cities, it would be interesting to see if one, it was collateral damage. In other words, they did have underlying coronary disease, chest pain didn't come in, or two, if it was directly related to COVID or a COVID complication. Either way, just showing that there was an uptick during this period of time while people were staying home is going to be just an interesting thing, and see if there's any pattern as we go across the United States. Some cities are not showing it, some cities are. So, okay. All right, then let's go on down. I didn't, San Francisco, anything new from your end? Chris, you're still on the line. I'm not sure if you are still. It was a great job you did earlier. He may have had to get off. Chris Caldwell, you're still here?
Yep, still here.
Yeah, what's happening in San Francisco? Are you guys holding steady there as well? Anything new there?
We're holding steady. This is now, we've had 4 straight days where the number of ventilators that we've added have equaled the number of ventilators that we've taken patients off of. So obviously that's a hopeful sign. We have not tipped over the edge in terms of being overwhelmed, but have kind of sit right on that edge for almost 6 days now. So we're interested to see what these next days look like. Our transports are still down a little bit, but they are starting to pick up some. So keeping a close eye on it, but holding steady.
Okay, got it. Hey, Joelle, you were on the phone before. Are you still there? Or you're Chris from San Diego? I don't know if you're still there or not. I think she had to get off. So, well, we'll check with her next time. We had a good report last time from her. One thing, by the way, while I'm thinking about it, since we're on the Pacific side, I did contact some of our friends in Australia, and I talked to Det Velasco in Manila, and they're facing a lot of the same things. They're pretty heavy there, and again, the volumes are down for all the other types of cases, and COVID way up. They've actually created similar things like tents where they actually treat the COVID patients outside the hospital that are not critically ill, and a lot of them are actually just waiting to get a bed inside. And so they were hit pretty hard. Overall, their troops were doing okay, but they were creating special vans now that actually handled COVID patients. So they are pretty all suited up, and they are using PAPRs freely there in in Manila. All right, I'm going to jump over and maybe hit Philadelphia, because I figure that might be the next thing. And Meg, be prepared. I'm coming to you next in New Orleans. So Crawford, anything new happening? Are you guys picking up steam yet with your patients coming down from New Jersey and New York? Crawford Meacham from Philadelphia. Crawford, can you hear me? He may be off. Well, I saw his name up there, so he may be off as well. If you're there, you can pipe in, Crawford, let us know. Okay, Meg Marino down in New Orleans, since you guys got hit so hard, what's the latest there? Meg, are you there? I saw her on the line before, so.
Yes, hi, can you hear me?
Oh, good, yeah, now we can hear you. Yes, go ahead.
Sorry. We're actually doing really well. We're still seeing a huge uptick in our cardiac arrests. We are working hard to provide support for our sick employees. So we've been doing wraparound services, providing meals and housing, and trying to make sure everyone is cared for, and making sure that we have mental health services available. And we're trying to figure out what the next steps are in really helping us get through the next couple of months, and kind of regrouping this week to see if we can make a new strategy to be prepared. So we really appreciate all of your help in this. Thank you so much.
Oh, you're really welcome. And just please reach out to us. Call me anytime. You know that, around the clock if you need anything. Let's jump.
Paul, it's Crawford.
Okay, Crawford, tell us about Philadelphia. What's going on there?
Things have actually still been status quo. We've got our quarantine hotel in place. We're having a second, we'll probably be adding quarantine hotels and facilities for both the public and for first responders. Our field tent, or our field hospital, essentially is almost ready for operation. We're talking about screening homeless people and folks in our high opioid use region for COVID. And that, otherwise, patient volume is still lower than normal. Hopefully it'll continue to stay that way.
Yeah. Okay. Interesting. All right. So thanks a lot. And I was figuring you were going to get hit next. So it sounds like you're on top of that so far, and I hope it stays that way. And thanks for looking at all those other issues that you're talking about. Is there commingling of the first responders with the public at large, or are they separate hotels?
They're separate.
Okay, got it. Okay, cool. All righty, that's what I figured. I just want to make sure that was the case. All that. Let's jump all the way over to Libby Char in Honolulu, if you don't mind. Libby, if you're around, can you give us some what's happening out there in your neck of the woods, so to speak?
We're hoping that our numbers are kind of plateauing at about 500, or at least slowing right now, 500 cases statewide. And really grateful to everybody because the information that you share on Eagles has been tremendously helpful for us. We finally got a bunch of filters, so now I got to go back and see if they're mechanical or electrostatic.
Yeah, right. Exactly. It's great. Okay, good. Anything else? What I was going to say is, if we can, let's jump back to maybe Scott. I was going to go hit the middle of the country first because I hadn't talked to him for a while. But Scott Gilmore in St. Louis, what's happening out there in the city by the river?
So actually in St. Louis, we haven't hit our peak yet. However, we have stood up a regional COVID task force amongst the hospitals, and surprisingly, our ICU beds, the number that have been occupied by COVID patients, has dropped by about 15%. So that's a good sign. So
Yeah.
It looks like our social distancing might be helping, and hopefully the trend will continue.
Hey, I got to tell you, I heard just as an interesting perspective is that I feel like I've been doing more socializing, calling people, talking to them, seeing them, here on these webinars. And someone made a great point the other day. I was on a conference call at the University of Miami, and the professor said, it's not social distancing, it's more physical distancing. And I said, good point, and tactical distancing, because there has been, actually, this has been very useful. We're talking about the mental health issues. This is very cool because we're not all feeling alone. So this has been terrific, having these calls. So let's see, let's move on. Chris Zuber, I haven't talked to you for a while in Orlando. Can you tell us what's happening down there in your land of the mouse? Okay, so.
Hey, Paul, we're doing pretty good. It's the status quo for what the new status quo is. Our volumes are still down both in the hospital and from the pre-hospital side. The parks are still closed here. We have no tourism to speak of, so that I think is a big determinant on our numbers. And Universal announced they're going to be shut down pretty much until at least beginning of June. So we're optimistic, but preparing for what could be our peak here in the next week to 14 days.
Okay, great. Hey, Jeff Goodlow, get ready because I'll come to you next. But Jeff Hayes, can you get on by any chance? Tell us what's happening in Austin, Texas.
Yeah, thanks, Dr. Pepe. We're pretty much status quo here. We haven't seen a big spike. I think we haven't hit our peak yet. Some of the modeling coming out of the Dell Medical School is telling us we're still about 2 weeks away. We've got isolation facilities set up both for public and first responders that are separate here. And call volume for us is actually about 20% less than normal. All our docs are telling us that the ED census is also very low. So we're just kind of waiting.
Okay, and then it's a huge campus there with the University of Texas. Did the kids all split like we heard from Madison? Did they all split at the spring break time? And were they partying hard in the bars beforehand? That kind of thing.
Yeah, they bailed pretty quickly. Once South by Southwest was canceled, they left the city pretty easily. Of course, we had that group that went to Cabo and all came back COVID positive, and they're all isolated, still on quarantine. Most of them here in the city. A few actually did get to go home and isolate at home, but most are still here.
Okay, got it. All right, well, thanks for doing it. And any other nuances? Everything's been sort of everything you're hearing. There's nothing else to contribute to us or any special problems that you're having that we can help you with?
No, sir, not right at this moment, but thank you.
Yeah, good. All right, so Jeff Goodlow, what's happening in Tulsa and Oklahoma City?
Yeah, holding pretty steady. Volumes are down just a bit from the historical norms. Always proud of our frontline folks. Started field-based telehealth last week and ramping up on that. We're holding steady. Thanks.
Hey, listen, and you're on the board of directors at the American College of Emergency Physicians. And so is there anything percolating up from that end that we should know about?
Yeah, always new stuff coming out daily on the ACEP COVID site. Easiest place to find your way there is just ACEP COVID, and that will take you to the top hit. Really impressed with our staff and many members that are graciously volunteering their time and talents to keep that the most up-to-date resource for us.
Yeah, I was recently asked about the thing that the American College of American Heart Association put out about the resuscitation thing, and we said that we actually got to review it and didn't have a whole lot of problems, because I think what's going to end up doing is that you guys are the FDMs, the final decision makers about what's going to happen in your cities, and we're there to support you and also support your people. Some of the stuff I saw in there I would not agree with, especially on the issues of the ventilatory management, and but that's my own personal opinion, of course, and hopefully I had some data to back that up. But the other thing I was going to say was, I think the most important thing is that if we have to have these decision making going on, especially on the part of the paramedics who are now feeling guilt, as Ed put out, I think the best thing is to give them the guidance, from my personal opinion, is to give them the guidance that, you know, if this was your family member or my family member, what would you do here? And I think that's that would be my perspective. I don't know, any reactions from your end, Jeff, on how you approach this, because you're right in the middle of all that.
I think we just have to take the best evidence base that we can. We have not made drastic changes in our resuscitation decisions at this point. I don't think we're going to have the crush of cases that we originally were concerned about. So that's a wonderful thing.
Yeah.
But I think it still gives us an opportunity to be thoughtful about the cases we do encounter. And I think, you know, most of the country is not going to have the New York, Detroit, Seattle experience, but I think we still have to be prepared to make some thoughtful decisions on cases that are confirmed COVID positive, and then we encounter that person in a cardiac arrest state. The end result, as we know, is very, very, very poor prognosis, and I think that does have some serious food for thought whether we initiate resuscitation or not.
Right, on the risk management approach. So whatever you guys do in your areas, let us know. We know this is difficult, and we're there to back you up if you ever get second guessed on it. Let's go down 35. How's Fort Worth happening?
We're doing okay. As a couple others said, our volume is actually really, really low. We're not seeing the peak in cardiac arrest that Denver saw. And so far, we're hoping that our social distancing works. I think we're still probably not at our peak either in our area, but we're just prepping in case we do.
So you've had I mean, you actually probably have an easier way of getting this done because you've had a robust, community paramedic programs we talked about before. Are you actually getting into some challenges there, or things that you didn't expect that you'd run into doing your kind of community outreach?
Well, especially early on, it was an interesting discussion because we were essentially putting these folks in a bunch of high-risk patient scenarios because we were doing proactive home visits. And so it was more of a philosophical discussion of, can you take a mobile integrated healthcare visit and make that a video visit so that we're not traipsing between high-risk patients and potentially spreading it amongst them. So we've found a balance with it now.
All right, I'm going to jump across to the East Coast and talk to Lakshmi out of Atlanta. What's happening there, Dr. Kumar?
Hey, so we are status quo as far as numbers are concerned. Numbers are down both in hospital and pre-hospital. Our MIH unit, though, is fairly busy because a lot of the clinics are canceled and the subspecialty physicians are using us to go check in on patients that they're not totally comfortable with just teleconferencing with. So our MIH group has been fairly busy.
Okay, can I make sure I know what your MIH is for those who may not know it and stupid people?
So it's our community paramedicine group, and it's essentially a nurse practitioner and a paramedic or EMT paired together who go out and do the non-essential visits and the follow-up visits.
Yeah, okay, good. Let's, go ahead. Yes, please go ahead.
Our Georgia World Congress Center, they're opening a 200-bed hospital. Per se, the governor just announced it, and we're going to check it out. I think he's preparing for the spike. Got a bunch of wellness initiatives, limiting our emails to 1 a day, virtual live meditation sessions. We have site WebEx group support sessions, which have actually, like with a team approach, that have worked fairly well. And we are creating a separate phone line managed by our nurse practitioners. That's about it.
Okay, thank you then. Let's go ahead. Let's just run across the country out to Colorado Springs and get a breath of fresh air there. Stein, what's happening in your in your neck of the woods? And then others, be prepared. I'll be calling on you soon. Erica next, for example. Stein, what's going on in Colorado Springs?
Yeah, hey, Paul, can you hear me okay?
Yeah.
Okay, great. Yeah,
By the way,
interestingly, we are not.
I'm just down the road from you in the Grand Canyon, if you can see on my background. So, all right.
Oh, I see that. That's great. Yeah, interestingly, we are not experiencing the huge spike that Denver, just an hour and a half north of us, is experiencing in cardiac arrest. However, we are experiencing a little increase, and we have just launched our new guidelines, our new field protocols for cardiac arrest. And we've been working with Mike Levy over the last couple of days, organizing some of the survey questions and for the Eagles, and very interested to see how people are potentially changing their cardiac arrest program in this COVID era. We also are dealing with our homeless populations and using certain dormitories and event centers to cohort them. And we are actually seeing a bend in the curve. So maybe our social isolation is starting to work. We're not, and we have not experienced the huge increase of numbers that we were once anticipating a couple of weeks ago. So we're kind of holding steady at the moment. We also don't have any filters for our ambulances. And so that's something that we're dealing with.
All right, and then thanks again for all the other issues. And if you can't get a hold of me later to talk a little bit about the website as well, so we can get up to date on that. Maybe if you got some time this afternoon. Okay. So, all right. So so I'm trying to remember who I was going to be calling on next. I'll tell you what. Tom Collins in Cleveland, are you there on the line? You were before. Yeah, there you are. I think. Tom Collins, are you there? Can't hear him yet.
Hey, how's that?
Oh, good. There you go. Hey, Tom, how are you?
Okay. Good. Now, we're having a very similar experience to everybody else. Our volumes are down. The ED volumes are down. ICUs are able to handle the COVID patients that we have. Looked at our cardiac arrest data, and we're not seeing any spikes in cardiac arrest right now or over the past couple of months. Probably the big things we're working on right now are pre-plans with the LTACs and the skilled nursing facilities, as well as we're looking at a state mandate coming out that the health departments are going to have to notify all first responders about the location of COVID patients. So how are we integrating that into our response information?
Yeah. Okay. Fantastic. I think it's interesting. It sounds like this is very heterogeneous where we're having these spikes. So we got to, as we say in public health, the public health arena, is there ecological differences that we need to be examining? It's kind of interesting. So, all right. So let's move on. West Palm Beach, Florida. Let's just go down to Florida. Ken, do you have anything to tell us about West Palm Beach or even the state of Florida, since you're the state Florida medical director?
Yeah, sure. So over half of our cases are in Southeast Florida, Palm Beach, Broward, Miami-Dade. That continues to be the hotspot for us. The good news is the last 5 or 6 days, we've seen the plateauing in the number of new cases. And the modeling is showing that we're not going to run out of either ICU beds or ventilators, all good stuff. We've been focusing on getting high-flow nasal cannulas in stock as well as a ventilating sparing protocol, like many others have already talked about. We are a little concerned about what just happened with the holiday weekend, and if anybody sort of stopped doing their good social, or in your case, what you said, physical distancing.
Yeah.
If they stop doing good physical distancing, and we're worried that we might see a spike afterwards. But so far, it's looking promising, and we're hoping that trend continues.
Yeah. Okay, that's great. And thanks again for all the great work you're doing out at the state. Sounds like you're making major differences. I appreciate that. RJ, what's happening up in St. Paul? And then I'm going to go to Mark Conrado in Minneapolis after that. Mark, if you're still on the line. Okay.
We're doing the same thing as they're doing in Cleveland. It's Cleveland right now. The governor has passed an emergency order for dispatch centers to inform first responders whether or not the patient has COVID. Other than that, we're flat, calm before the storm.
Okay, let's drop across the river to Mark Conrado in Minneapolis.
Hey, Paul. Actually, the question regarding cardiac arrest was interesting. Our cardiac arrests are down by about 30%.
Jeez.
Starting in, went down by about 20% in February, 30% in March. I did think it was interesting about contacting the ME to see if they've seen, because I don't even know if they're testing for COVID.
Ah.
So that is on my to-do list today, is to check with our Hennepin County ME and see do they have the ability, and have they seen a rise in deaths.
Yeah.
But
Hey, Mark,
we're staying, the local area is staying quite good. We have quite a surplus of ventilators and ICU beds currently.
Hey, Mark, this is John. We're seeing this from Portland. We're seeing the same thing. Your numbers are amazingly similar. I just ran the numbers this morning on cardiac arrests. So, Paul, it would be very interesting to see what if you actually marked the social distancing when we started in Minneapolis versus Portland. We started social distancing on March the 13th right now. So if you actually go back, I think communities that are much more widespread, and real reason I'm talking to Mark is that we're not tight in like New York City. Our communities in Portland are like Minneapolis from a density point of view. Fascinating.
Yeah. So I may talk to you later about maybe leading up a study on that and getting everybody to get some of that information. I think that's fascinating then, because there's obviously heterogeneity here. So, and it may have to do with that. It's fascinating when you see some of the countries that are that didn't start the social distancing, physical distancing early on, and just in Europe they're just spiking up, whereas, as I said, in others they're just they're way down. So and they started only a week earlier, and so that's really interesting. So I have a couple names here. Sparkman, I don't know who that is. M. Sparkman. I don't know if you're one of the Eagles or just it's a pseudonym, or there's a Wampel RD online. I need to probably know who you are so I can call on you if you're one of the Eagles. I don't want to leave any of the Eagles out. Try to see if I've left anybody out. Chuck, are you still there? Burnell from Acadian, you have such a large.
Sir, I'm here. So
yeah, anything
I'm here. Can you hear me?
Yeah, what's happening with your folks?
So I think I'm cautiously optimistic to say that I think we're starting to flatten and turn down on numbers. As far as cardiac arrests, I'm recompiling data this morning. The initial data looked like it was flat, but I think it's actually going down. We had a few extra included things that shouldn't have been in there, but I think we're going down. As far as transports, we're still 20-30% down overall, but our vent transports have taken probably a 30 to 40% decrease in most markets, and that's all interfacility, mostly related to COVID. So I was encouraged by those numbers. From an employee standpoint, one of the things I'm going to send out later is I'm curious to know how many people have employees out percentage-wise by organization. We've returned half of our employees that were COVID positive back to work, which was only for almost 3,000 frontline providers. We only had 33 positive COVID, 16 are back working. And I'm just curious to know if my number is in line with everybody else. So other than that, the EAP/CISM thing, we've been doing that. I have not had any uptick in utilization of that.
How many providers do you have across Texas and Louisiana? That's your main areas, right?
About 1,500 each, a little bit more in Texas right now.
Okay, got it. All right.
And then we have 700 in industrial offshore is another fact. That's all industrial medicine.
So I'm going to get ready to wrap. I'm going to have two more people probably get on. Well, Erica, I got to get you first, and then David Miramontes. Erica, what's anything new from Kansas City I need to know about, or things we could do for you?
Yeah. So we actually had our first line of duty death yesterday because of virus. So I was curious if anybody has had experience with the line of duty death funeral in the midst of coronavirus, and what are some lessons learned that we could potentially apply?
Well, it may be you telling us, but actually, so that'll be good. Anybody else have any experience with it yet? Hopefully not. Okay, and then is that amongst the EMS crews, not police, right? Okay.
Right, it was one of our EMS.
All right, got it. Well, then let's stay abreast of that. I'll give you a call later, okay? Hey, David Miramontes, give me a shout from your end if you don't mind, okay?
Sure. Can you hear me, Paul?
Yep. Are you taking
Good.
Mexican flu by any chance?
No, I was in quarantine last week actually because I was sick.
Okay.
But, I don't have COVID, thank you. So we are progressing along. We have flattened the curve. We have, unfortunately, our first firefighter that's positive. So now we're going through the whole process of, was it on that run or was it community spread? And
yeah,
what's the workman's comp issues? And everyone's losing their minds, of course.
Yeah.
So we have, so that we're dealing with that. So far, we're doing very well. We have decon stations throughout the city to help with not only our ambulances, but any regional ambulances that come into the city. So they can decon quickly and they get back on the road to their far-flung counties that are in our region.
Yeah.
So those are kind of a couple of things we're doing right now. Drive-through testing is rocking it. We're doing 400 people a day, getting our results back within 24, 48 hours. And the way we did that here is I'm the prescriber, so I prescribe for everybody. So everyone could get a test under Miramontes' license. And they, MedCom just does a couple symptoms. You got symptoms? Great, you get tested. And this has been working out very, very well. And this, again, it's track. We're very fortunate because we have a collaboration of people doing it. So it's nurses that aren't working in the hospital. It's a couple of medics supervising public health. It's this mishmash of people that are coming together for the community good.
Tell a little bit, just for anybody who may not know it, what STRAC is, okay?
STRAC is a rack on crack, so to speak, a regional advisory council. And so it's not your typical hospital coalition. It's really well funded, well supported. And our hospitals work really well together in times of need. Now they compete fiercely for market share, but they cooperate in regional efforts. So it's a really neat little place. So we're able to do stuff very quickly, very efficiently. We have a huge checkbook that we can put out and get reimbursed later. So it really, it kind of fills holes wherever a industrial or a governmental agency can't do stuff. We fill that need.
So listen, I think on Friday, I want to talk about this issue about harvesting plasma. And you guys already had a really robust program going with the blood bank. And so I think that we want to talk about this next time. But I want to talk about the rationale and what we know about it and where we're going with it, because that's a big thing now in the public gets, beyond the antibody thing, that the antibody Wild West thing, that's the next one. So I will be talking about this issue about seriously serializing serum harvesting next time on. And so be prepared for that one. And we'll talk a little bit during the week.
Maybe you could tune up John Jew and Osterkamp to try and look at the research and what the current data is in their worlds to see how effective or not effective or what the data is.
Yeah. And there's some good reports out of Florida. I don't know if Peter Antevy is still there. You be prepared to talk to us a little bit, and maybe John on Friday. Okay, so as we get to it, I want to kind of wrap it up unless there's anybody else who's got something. But AJ Heitman, I saw you were on the line. I got an interesting question for you. Your conference, the EMS Today, was in Tampa around that first week of March, and we know some people got sick soon thereafter. Was it from there? Was it elsewhere? Have you heard a lot of reports that came out of that Congress? Nothing against the EMS Today per se, just that another social gathering, large gathering. There's reports of other conferences that caused problems. What'd you pick up on it? You have any sense of that?
Yeah, the only contact that we had was one physician from Florida at a Florida State meeting on the 4th floor. And I don't know who it was, and I don't know of anybody else. I know one person said they self-quarantined because of it, but we heard of no spread from it. It appears to be somebody who came to a meeting that we had in conjunction with the Florida conference, and then left the meeting. Never was in any other sessions, etc.
Okay, good. So that's fantastic. I want to make sure that it'd be just an interesting thing, because there's reports that I think I saw a New York Times article, whatever, about this one conference that was held, but I think it was in Boston, and that did spread things around. So I'm glad to hear that. That's good news from that end, because I want to make sure our other folks out there are okay. I think that's probably a good wrap. Anybody else out there that just wants to throw in a comment before I call it quits here? Otherwise, everybody okay with the formatting here? Are we doing okay? I know we all like to get off this sooner, but it's been interesting stuff for me. So I hope it is for you as well. Hearing no objections, I guess I'll go ahead and cut us off at this point, and then we'll see you again on Friday, same time, same station, and all that. Anybody
Okay.
else? Anybody else want to pipe in before I go? If not, okay, sayonara. Bye-bye.
Bye.
Yes, yes.
Thanks, Paul.
Take care. Peter. Yeah, Peter, go ahead.
No, I said thanks.
Oh, you're welcome. Nice background, by the way.
I'm here on the beach. I don't know what you guys are doing.
Is that Hollywood Beach? Is that Hollywood Beach?
Right.
Of course. The weather looks crappy.
It's closed now. It's closed now.
Yeah.